when you talk about breast cancer families, I have a breast cancer family. All the women had breast cancer. I actually grew up thinking that you just get breast cancer. Can't believe I still can't tell this story without crying. Linda died of metastatic breast cancer 1 month after Whitney released that song. I became the first fellowship trained breast surgeon in Philadelphia, and he tells me that I need surgery and chemo radiation. I'll tell you, when those words are coming at you, it's a different story. And something told me there's more. There's another way, another answer. Go find it. In order to help millions of women prevent and heal from a breast cancer diagnosis at any age, at any stage, healing can happen. I'm just trying to figure out how not to die.
Well, hello, everyone. I am Jill Chmielewski, and I'm joined by Dr. David Rosensweet and Dr. Holly Papanik, and we are ecstatic we've been looking forward to this day for how long? I don't even know. I think since our Instagram live a few weeks ago, Jen, I had shared that with both Holly and Dr. Rosensweet, and we were all just like, we have to sit down and have this conversation. So we want to introduce you to Dr. Jenn Simmons, who is a former breast surgeon, now functional medicine doctor, host of the podcast, Keeping Abreast with Dr. Jenn, which I want to put a plug in for. I've listened to, I think, every episode. I love that podcast. I share it with everyone that I know too. It's so great. And we also were just singing your praises before we started recording because you've released your book this week. Like, we get to get you here. It just so happened, right? It happens
it's like
to be
hard to believe, but
yes, the Smart Person's Guide to Breast Cancer. Yes,
the Smart Woman's Guide to Breast Cancer.
Yes.
It is available on Amazon, and it was a really big box to check, right? Like, I'm very into checking boxes. Like, I did that. It's done. Next thing. Although I made a very false promise to my husband because I told him I wouldn't write another book for a while. And then the second we hit publish on that book, I was like, you know what my title for my next book is? Steam coming out of his ears. He's like, do you ever stop? Do you ever stop? But people like us, it's hard to stop.
Yeah.
It's really hard to stop because we're always thinking about, oh, well, I should have added this, or I should have added that, or I have another way to help people. And, we're living lives of service, right? Mm-hmm. And there's always something else to do, always.
Yeah. Yeah.
So
well, we're glad I'm
really going to try to get through the summer, although I think it's very unlikely, but I'm going to try.
Yeah. Well, and we were just saying before we started recording, Holly read the whole book last night. So for everybody that watches and listens, that's how great it was. You couldn't put it down, you said, because it's such important information. I know from the first book that was a smaller version of this book, how great it was. So I'm so happy to hear you say it, and I can't wait to get my copy that's coming today.
Yay!
Yes, it's fantastic. It's so full of information. It's an easy read. It's a fast read. I kept wanting to turn the next page to learn what else. And as a physician, there's so much here that I even learned. But also just as a woman, it is just fantastic. Thank you so much.
Thank you.
And look, I have an unusual question.
Look what I've been hard at work at.
I have an unusual question.
Yes.
Could you tell us how you got here? Like, when did all this originate? Like, even when you came to Earth? Just curious about your personal story and your journey.
If you don't know how that happened, we have a way bigger problem. Actually, I came to Earth because my dad didn't want to go to Nam. I mean, if we're being honest, my father was in the Air Force and it was either go to Nam or have a baby. So he chose to have a baby. But my mom had the baby, obviously. So I come to the breast cancer space really, really organically in that when you talk about breast cancer families, I have a breast cancer family. And my grandfather was one of 13, and all the women died of breast cancer.
Wow.
And the next generation is my mother's generation, and all the women, with the exception of my mother, all the women had breast cancer. My mother had colon. I don't remember a time in my life where I didn't know about breast cancer. It was an ever-present element of our lives. And I actually grew up thinking that you just get breast cancer. I mean, that to me was an eventuality. And even when I went into medicine, even when I became a surgeon, I never thought if I would get breast cancer. I thought when I get breast cancer. But the real turning point for me was when I was growing up. I had a first cousin. Her name was Linda Creed. She was a singer-songwriter in the 1970s and 1980s. She wrote all the music for the Spinners and the Stylistics. She was beautiful, brilliant, larger than life, lit up every room that she walked into. She had an energy about her that was so electric. She was my hero. She wrote 54 hits, and her most famous song was The Greatest Love of All. So she wrote that song in 1977 as the title track to the movie The Greatest, starring Muhammad Ali. And then at that time, I thought she was as famous as anyone could be. And then in March of 1986, Whitney Houston re-released that song. And at that time, it would spend 14 weeks at the top of the charts. Only Linda would never know, because can't believe I still can't tell this story without crying. Linda died of metastatic breast cancer 1 month after Whitney released that song. And I was 16 years old when my hero died. And her life, and ultimately her death, gave birth to my life's purpose, because I never wanted another woman, another family, another community to have to suffer the way that mine suffered. And so I did the only thing I know how to do. I became a doctor. I was the first doctor in my family. I became a surgeon. I became the first fellowship-trained breast surgeon in Philadelphia. And I did that really well for a really long time, all the while thinking my shoe was going to drop. And I was about 15 years into my career. And I should preface this by saying that my aunt, my mother's sister, who I am most like, genetically, physically, everything. About 10 years before her breast cancer diagnosis, she was diagnosed with Graves' disease. So I was about 15 years into my career, having a very successful practice. I'm running the surgery department. I'm running the cancer program for my hospital. And I'm a wife and a mother and a stepmother and an athlete and a philanthropist, and I have all these balls in the air. And I go from, in one day, probably one of the most high-functioning people you've ever met, to I can't walk across the room because I don't have a breath in my body. And I have this intensive 3-day workup. And so happened on a Tuesday. On Friday, I'm sitting in the office of my friend and colleague and physician, and he tells me that I need surgery and chemo radiation. And despite the fact that these are things that I say all day, every day to people without hesitation or reservation, I'll tell you, when those words are coming at you, it's a different story. And all I could think about in that time and space, other than feeling like I was in Charlie Brown's classroom, right? Like, wah, 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 wah. Like, so underwater, what is happening here? And something told me there's more. There's another way, another answer. Go find it. And I walked out of the office that day. My friend told me that I was going to die if I didn't have the treatment. And listen, I knew what he was saying. He was telling me that this is the standard of care. This is the gold standard. I'm running a cancer program. I know what the standard of care is. I know what the gold standard is. But something I don't know what to call it. Call it God, call it universe, call it whatever you want to call it. We all have that internal voice that guides us. And mine said, go look, go find it. And so I went on a journey to heal myself. In the beginning, I don't want to pretend that this was about anyone else. I wasn't trying to cure the world of breast cancer. I thought I was doing that, right? I thought that being a surgeon, I was doing that. So I was trying to figure out how not to die, like Michael Greger. I was literally just saying, I have young kids. I have a whole practice. I have people that count on me. I'm serving a real purpose in this world. I'm just trying to figure out how not to die. And I was very fortunate very early on to be in a lecture hall listening to a bunch of people speak. And one of the first speakers walks on stage and introduces himself as a functional medicine physician. And at this point, I'm a doctor for 20 years. I'm my snooty booty self, don't know anymore, still have my blinders on. And I said, there's no such thing as a functional medicine physician. What is this quack talking about? Turns out the quack was Dr. Mark Hyman. And what he was going to tell me in the next 2 hours was going to completely change my life, my patients' lives, and forever change the way that I looked at my role in this world. And I knew as soon as I dialed in and listened to him, I knew that the reason that I got sick was so that I could be in that room on that day listening to him speak. Because God put me here with real purpose, just like he put all of you and everyone here with real purpose. And in order to serve my purpose, in order to help millions of women prevent and heal from a breast cancer diagnosis, this is what I had to do. This is the road that I had to travel, and this is what I needed to hear. And I don't think that I would have ever heard it had I not been experiencing it. And it took me 3 years. It wasn't an overnight fix. There is no such thing as a quick fix. So I don't want to, I don't want to mislead anyone and think that, they're going to get better in a day, because healing takes a while. But I want people to know that even when you're very, very sick, healing can happen at any age, at any stage. Healing can happen.
Wow. That I have goosebumps, Jenn. That's amazing. I mean, and to your point, I think so many providers feel like you have to almost have this personal experience to take the blinders off oftentimes. So and I've heard your story on your podcast, and I know you had one with Dr. Tina I was listening to, and I feel like it's such an amazing story. It's so inspiring, and that you've taken this thing that has happened and just turned it into, it's just given you that like clarity about what you need to be doing, right? It's
For
amazing.
Sure. I don't want to paint too rosy a picture though, because being sick really sucks.
Yeah.
And it's really hard. And it's hard to heal when you're suffering. Really hard to heal when you're suffering. And the very best thing that anyone can do when they're in that position is build a really good team around you and find a community, because you need the strength of others. And I tried to do way, way, way too much alone because I didn't know better at that point. Yeah. And so community, trusted guides, that ultimately that's what we are. We're trusted guides. We are people who have either walked it or have seen it enough times to know that this is how you do it. This is how you do it.
Can you share some of like, did you not have any surgery or chemo or radiation?
I didn't. Now, listen, that is not going to be the solution for everyone, right? Like, I am not throwing the baby out with the bathwater. And I know that there are going to be some people that need some, if not all of the modalities. So, when lots of people get to the point where their proverbial sink is overflowing and they need a quick fix, which is what surgery and radiation and chemotherapy are. And we can talk about those situations and circumstances, but suffice to say that if your sink is overflowing, you need to mop up the floor. And that's what surgery and chemo and radiation and all these conventional treatments do. But ultimately, you can't mop up the floor forever. And you're going to have to figure out how to turn off that faucet. And if you have a slow leak, maybe you can get away with not doing surgery and chemo and radiation. I was very lucky that I came into it pretty healthy, pretty strong. So I got a lot worse before I got better, a lot worse. And maybe it was a little bit of luck, a lot of God that allowed me to get through it and to see the other side without doing any of the conventional stuff. But I don't judge anyone. If what is in your heart is I need surgery, I trust that. People's intuition doesn't lie to them. And we all need to dial down into that inner voice and trust it. Conversely, if you go into a treatment saying that it's not going to work, I can promise you it's not going to work. And I have a family member right now who is going through it. And what I'm saying to her and what her medical oncologist is saying to her are two very different things. And I'm not saying no because I never say no. I say do this and right. Like the things that I talk about, the things that I recommend, that's the absolutely yes, right? And it's whether or not the conventional treatments will add anything is the question. And her medical oncologist is, telling her you have to do chemotherapy and saying things like, what you eat doesn't matter and fasting doesn't matter. And, all the things that I talk about that I know have a tremendous influence on how you do both in terms of tolerating the treatment, response to the treatment, and long-term outcomes. And yet, I talk about fasting and she says things like, well, my medical oncologist told me to maintain good nutrition. So it doesn't sound like those are the same things. And their idea of maintaining good nutrition is don't lose weight, eat as much ice cream, pizza, and Boost that you want. So, unfortunately, we're still up against a very broken system. And I try not to take it on and I try not to convert, right? Like you can't sing to the deaf. They can't hear you. So I try to help the people that are already open. They're already saying there must be something more. They're people like me who, when faced with adversity, they say, is there anything more? They're curious. I think that is the main thing that we all need to maintain, right? Providers especially, we have to stay curious. I don't remember who said this. Maybe it was Mark Hyman, but if you're not embarrassed about something that you did 6 months ago, you're not learning, right? And we are all obligated to continue to learn. I mean, this is why I haven't slept in a year and a half, because I slept with a notepad by my bed. And every night in the middle of the night, I was like, oh my God, wait, I have to add this. Oh my God, I have to add this. Like we're constantly learning and we're obligated to do that. If we're really going to serve people, then we have to maintain our curiosity. We have to keep asking questions. We have to keep searching for what's better.
Jen, I mean, this is just a wonderful, touching, heart-touching, inspiring story to hear. And I have a funny request. We also know that you've got some basics around breast health, self-breast exam. I would love to circle back to this healing process. Perhaps whatever the time is, I would so much love our professionals and our general audience because I've listened and heard, and and you've got some stuff that people need to hear about breast diagnosis, breast health, healing, precursors to breast cancer. So, wow. And I'm so grateful that you were willing to go into your heart and tell your personal story.
Yeah.
It's extremely inspiring.
So, I would love to talk about prevention because that is a question that is just never being addressed. In this country, we talk a lot about prevention, but then what comes in the conversation of prevention is screening. And that is not prevention. That's early diagnosis. The number one thing that we can all do to prevent breast cancer is to never have another mammogram. That is the number one thing that we can all do.
Would you elaborate on that, Jen?
Yes,
Would you
absolutely.
go into some details?
Yes.
We've got a very sophisticated audience that would love to hear the molecules. Thanks.
Yes, absolutely. So it's funny that if you ask any radiologist, does radiation cause cancer? They will unequivocally say yes. Ask the same radiologist if mammograms cause cancer, and they would say no. We have packaged mammogram up in a pretty little package and gave it a name. We didn't call it a breast x-ray. We gave it another name, and we have turned a blind eye to the harms of mammogram. So let's talk about what a screening mammogram is, right? We are talking about addressing the healthy population. I'm not talking about a diagnostic mammogram here. I'm not talking about someone who has a symptom. I'm not talking about someone who has already had a disease or identified something. I'm talking about the normal, healthy population. And when you look at that normal, healthy population and you take them and you x-ray them every year, starting at 40, because that's what the United States Prevention Task Force just announced a couple of weeks ago, starting at 40 and imaging them every year, although quite frankly, at least 25%, up to 60%, depending on where you are in the United States. I'm from the Northeast. We're upwards of 50% callbacks. These women are getting imaged twice a year, sometimes 3 times a year. This is a surefire way of increasing the breast cancer rate. So we know not only will we cause thousands and thousands, somewhere between 5 and 10,000 breast cancers every year with mammogram, we're also causing women to be treated for breast cancer. So we're overdiagnosing them and overtreating them. And in doing that, we are shortening their lifespan and significantly decreasing their quality of life. And I want to talk about those people the most. So if we just take the DCIS, the ductal carcinoma in situ population, okay? Now we're talking about 40,000 women a year. These women have a finding that would have never threatened their lives. No one dies of DCIS. No one. It has no ability because it is changes that are confined to the ducts. And when you look at the anatomy of the breast, there are no blood vessels or lymphatics inside of the ductal system. Any process that becomes systemic, the only way for it to become systemic, the only way for it to be life-threatening is for it to get into the bloodstream or get into the lymphatic system. DCIS, or ductal carcinoma in situ, has no ability to do that. So we take people with a finding. First of all, it's such a horrible misnomer. We should have never, ever, ever called it ductal carcinoma in situ, because once you hear that word, you can't unring that bell, right? Like when you tell your kid, don't do this, what happens? They do it, right? Because all they hear, you can't take away the negative, right? All they hear is what you tell them not to do, and they do it. So we should have never named it ductal carcinoma in situ, but that's a fight for another day. So we're taking these 40,000 women a year and we're treating them for breast cancer. So what does that mean? So they're having surgeries, and a large percentage of them, out of fear, are having mastectomies. And I want to be clear, those mastectomy scars, they run deep. Women are completely unprepared and ill-prepared for what life is like without a breast. When you operate on someone for pancreatic cancer, a thyroid cancer, an esophageal cancer, a colon cancer, these are internal organs. People don't notice the difference so much. I mean, yes, do they have the horrible burden of a cancer diagnosis? Yes, I'm not taking that away. But imagine coupling that with losing your sexuality, with losing your identity as a woman, with forever negatively changing your appearance. I mean, these are detrimental on so many levels. And they're just told, you don't need your breast. I mean, even if they're of childbearing age, you don't need your breast. You can just formula feed your children. You don't need your breast. And these women suffer such devastation from having had their breasts removed for a disease that would have never threatened their lives. So just the surgery alone. And if you get away with lumpectomy, let me tell you something. Having a deformed breast, because most surgeons, I was an oncoplastic surgeon, so I made sure that I got that silver lining in every single time and helped people to have the best outcome that they could have in terms of appearance and cosmesis. But most people are not doing that. There's plenty of surgeons that are out there still practicing the more is better, and they don't leave women with something that looks like a breast. And it's horrible because these women are every single day reminded that they had, well, they didn't have breast cancer, but they think they did, right? Every single day reminded of this. So
Then could I back up for just a moment?
Yeah.
How did women get the diagnosis of DCIS with or without a biopsy? Is it a diagnosis rendered by mammogram?
They have an abnormal mammogram because it's not diagnosed any other way. They have an abnormal mammogram, and they're told that their mammogram is abnormal. They need a biopsy, and they have a biopsy.
Yeah.
So, and I mean, listen, I wrote for many, many, many thousands of those mammograms, and I did many, many, many thousands of those biopsies. And I don't know how many mastectomies I did. I wouldn't sleep for a month if I had to count them and think about it, right? But our obligation to ourselves and to each other is that we learn and we do a better job today than we did yesterday, and we commit to doing a better job tomorrow. So, for all the ladies that I thought I was doing the right thing at the time.
Exactly.
Right? Yeah. I did. We all make the best decision with the information that we have at the time.
Exactly.
So,
again, interruption. Sorry to interrupt you, but
you can interrupt. It's your show.
There's so many topics that spring up. Is it so that women who receive the DCIS diagnosis, let's say through biopsy, that there is not an increased risk for a developing and life-threatening breast cancer? Or how would you state that?
Right. So a fraction of them, somewhere around 25%, will go on to develop invasive breast cancer if you do nothing different. But what do we tell people? We tell people to use this as an opportunity. This is an opportunity. This is your body saying, this isn't working for me, right? Like I'm whispering in your ear right now. Help me, because this isn't working. I'm asking you, I'm begging you. Help. And so I want people to hear that whisper so that they don't have to hear the screams, so that they don't have to get to that invasive diagnosis. And if we did that, if we took everyone who had calcifications on their mammogram and said to them, listen, you may have a process going here. Let's do an ultrasound. Let's make sure that you don't have a solid mass, because that increases the likelihood that there's already an invasive cancer. Now, I can argue that there's a large percentage of the invasive cancers that don't even need treatment, but let's let that go for a minute. If we were to ultrasound these women, which is a non-radiating study and does not put them at increased risk of cancer, and make sure that they don't have invasive cancer now, if we just took that 40,000 group of women a year and helped them to do all of those things that we talked about in the beginning, the fraction that would go on to have invasive cancer would be substantially less. But we're not doing that. We're telling people, go. The same thing that we tell them when their blood sugar starts to get deranged, when their thyroid studies start to get deranged. Come back when you have full-blown failure. That's what we're telling people. We're not giving them any advice. We're not giving them any guidance. We're not giving them any opportunity for change. And it's because, unfortunately, our system is very broken. It's only powered for failure. The only way the doctors make money, the only way the hospitals make money is when we fail. They don't make money when we're healthy. And that is part and parcel to why the mammographic screening program has become what it's become. Because we do 37.5 million screening mammograms every year. And it's a multi-billion-dollar industry. And they're not interested in changing it. And listen, I am not faulting the doctors, and I'm not calling them out. I went to the same medical school that they did. I trained the same way that they did. And I believed as much as they believe in what they're doing when I was doing it. By the grace of God, I had the opportunity to take my blinders off and be able to see it for what it is. And I have dear, dear friends who are still very, very engrossed and ingrained in that system. And they believe they're helping people. And they say things like, well, how can you discourage people from getting mammogram? You know, mammograms, do you tell them not to fly cross country because a mammogram offers the same amount of radiation as a cross country flight? Yes, that may be true. But when you go on a cross-country flight, that's scattered radiation. That's radiation that is diffusing around you. That is completely different than focusing all of that radiation to the tissues of the breast. It is a completely different thing. So that's like saying, well, you know, it's comparing apples to oranges. That's what it is. And for the people that
So
say
it's much more likely to be deleterious when you're focusing
absolutely,
then on a mammogram,
absolutely,
let
yeah.
alone, would you extend that to increased breast density when that's seen? You've described what happens in a radiation environment with
Yeah.
that, would you?
So even the radiation that is compared to the cross-country flight, that's the 2D mammogram. So in 2012, we introduced the 3D mammogram onto the scene. Now that is 2 to 3 times the radiation of the 2D mammogram. And when we look at breast cancer incidence, when we look from 1999 to 2020, and I looked at this data in depth because I looked for the purposes of seeing what happened after the Women's Health Initiative. Did we really have a decreased breast cancer incidence when nearly 70 to 80% of women who were previously on hormone replacement went off, and we stopped prescribing new patients? So if hormone replacement, which is what the preliminary findings of the Women's Health Initiative were, if hormone replacement actually caused breast cancer, we should see a precipitous drop off, right? But we didn't. And in fact, we only saw an increase until we get to 2012. And at 2012, that slope starts to go like this, because we're taking women who were getting a little bit of radiation every year, and we at minimum tripled it at minimum.
Wow.
And then with digital breast tomosynthesis, that's the 3D mammogram, it's abbreviated DBT. With digital breast tomosynthesis, if you have a dense breast or you have a large breast, you're going to need more radiation in order to penetrate that tissue. So the machine will auto compensate. So without the technician knowing, some women, if you have dense breasts or you have larger breasts, some women are getting 10 times the amount of radiation. 10 times. So Megan Smith does a really, really great job in her documentary, Boobs, the documentary. Don't Google boobs. You won't like what you find. But in Boobs, the documentary, Megan Smith does a great job of showing what is actually happening when women are getting these mammograms every year. And what we have to remember is the initial mammograms that were approved to screen, that was in the 1970s. The 3D mammogram, that was grandfathered in. There were not safety trials done for this. So these women who think that they are using technology that was proven to be safe, not true at all. And the mammograms save lives and mammograms save breasts, also not true. And when we look at the data, if you screen 2,000 women, you will potentially save one life and cause 10 women to be treated for breast cancer that would have never threatened their lives. The numbers don't work, and we are putting the normal, healthy population at risk for breast cancer. And when you are treated for breast cancer, this is not benign. So we talked about surgery, radiation, which is happening for all women who have a lumpectomy, who choose to not have their breasts removed. They're being offered, and most people are going through with radiation, despite the fact that radiation also does not save your life. And there is no increase in survival when adding radiation in. And it's not just causing fibrosis or hardness of the breast tissue. There's a lot of important structures behind that breast. So, as you walk back from the breast to the inside of the body, there's the chest wall and the musculature of the chest wall, and that gets fibrosed. There are the ribs, and when you radiate the ribs, you cause them to be very thin and fragile. So people can sneeze. I'm not exaggerating. I've had people sneeze and break a rib, and the mortality from rib fractures is not insignificant. So, that is a very major long-term complication. And then behind that, depending on which side we're talking about, if it's the right side, there's the lung. And people get lung fibrosis and even are at risk of a certain kind of lung cancer that is very rarely seen outside of people who get radiation. And it is lethal. And then on the left side, there's the heart. So people who are treated with radiation, they get acceleration of coronary artery disease. They get cardiomyopathy. So now we took people, when we're talking about the DCIS population, we took people who were never going to die of this disease, and we gave them heart disease. Women die exponentially more of heart disease in every generation past the age of 30. And women who are treated for breast cancer are 2 to 3 times more likely to die of heart disease than women who are not. So we took a problem, which we already know is a problem, and we made it 2 to 3 times worse for these women. What are we doing? What are we doing? How is mammogram helping these women? It's not. It's killing them.
You've spoken about how close. Speak about breast exam, self-exam,
Yeah. So my friend Sachin Patel told me that the patient is the doctor of the future. And for a lot of people, that's hard to hear because they don't want to take their own responsibility for their health, because it's a lot of responsibility, I know. And I don't want to make it seem like you're out there alone and you need to be responsible for your whole health. But the bottom line is that no one is ever going to know you better than you know yourself. And knowing what your breasts feel like is really important, because then you know what it feels like when there's a change. So I think it's really important for people to examine their breasts, know what they look like, know what they feel like. This should not be a daily event. I am not trying to make anyone crazy over their breast exam. If you are premenopausal, you're going to do your breast examination 1 week after your cycle starts, because that's the time of the month where your breasts are the least stimulated. Incidentally, everyone thinks they have lumpy breasts. So it's okay. Just own your lumps and know, what your lumps feel like.
Normal breast glandular tissue does feel lumpy.
That's exactly right.
That's normal.
Yes.
That's what a young woman should expect.
Yes.
And if I may interject something here, when I was in general practice, I used to do female exams, and I would do a breast exam, and I would go, this would be absolutely impossible for me to detect a change. I see a woman once a year. There's 100 or 50 or 5,000 lumps inside this breast. How in the world am I going to be able to detect a subtle change? Whereas she could detect a change.
Yeah.
She would just have to get to know her own lumps. Would you go into the weeds there and describe?
But I do want to be clear that I was at a point in my career where I didn't miss much on physical exam.
All right. Excuse me. I didn't. Thank you for the correction there.
But I do think that there's a technique, and I think that it matters. And I remember when I first started out as a breast surgeon, and I went to my gynecologist for an exam, and I remember how she examined me. And I went to the head of the hospital and I said, listen, can you do me a favor? Can you just let the OBGYN residents spend a month with me? Like I know that, because you're training them to be surgeons anyway. I mean, the bottom line is that's what OBGYNs are. People think that they're hormone experts, but they're not hormone experts. They're really trained to be surgeons. So I said, let them come spend a month with me. I'll train them to be surgeons, but I also want them to know how to examine a breast. Because the truth is, most women, when they have a breast problem, that's the first person they're calling. It's not like most women have a breast surgeon on speed dial, right? They're calling either their primary, but most of the time they're calling their OBGYN because they think that their OBGYN, because they're a female doctor, that that's the expert. So depending on the size of your breast, you're going to either do your examination standing up or lying down. You always want to do a visual inspection. You always want to look at your breasts. You always want to look at the size, the shape, look for any skin changes, redness, nipple retraction, skin retraction. You want to examine yourself with both your arms down by your side, turn 45 degrees, and then up over your head. So you always want to do a visual inspection. And then if you have small breasts, you can do this standing up. If you have larger breasts, you're going to want to lie down. You're always going to want to take gravity out of the picture. And you're going to want to put some kind of lubricant on your hands. So you can use lotion or oil or powder or whatever is going to work for you to just allow your fingers to smoothly glide. You're going to want to use your fingertips. That is the most sensitive part of your hand. And then you're going to go around your breast from outside to in a radial fashion. And you're just going to run your hand over the tissues of the breast. And when you find a change, it's going to feel like a bump in the road. But when you examine the breast like this and knead it like a ball of dough, you're never going to find any. So my technique was to sweep like this all around the breast. You can't do that when you can't have two hands when you're doing it yourself, because you want to keep that arm over your head. But you just go around in a radial fashion. And I promise you, after you do it a couple of times, you will know what you feel like. And this is something that everyone needs to own. I mean, we need to own our own health. You don't need to know how to solve every problem, right? But you need to know when there's a problem. You need to know when there's a change. And that it only comes when you have self-awareness.
You mentioned even the level of detection that can be achieved by self-exam, even in contrast to a mammogram. Would you describe that?
Yeah. So listen, we know from the Swedish studies that the level of detection between mammogram and your ability to feel it on physical examination is not much. It's about 4 or 5 millimeters. And ultimately, so that is a quarter of an inch. Ultimately, that's not going to make any difference. No difference at all. And this is actually why there's no survival advantage to doing mammogram, because, well, that's one of the reasons, is because that maybe 6 months between when the mammogram would have picked it up and when you pick it up on physical exam is a meaningless amount of time. So that's one reason why there's no survival advantage to mammogram. The other reason that there's no survival advantage to mammogram is because it is picking up a lot of lesions that would have never become clinically relevant. And it's really only the clinically relevant lesions that we need to know about. So when the mammographic screening program was designed in the 1970s, it was basically built on this foundational assumption that breast cancer growth is both linear and predictable. So if you found a breast cancer when it was small, before it reached some critical size, at which time it would metastasize, then you would be able to save lives and breasts. The problem is that breast cancer growth is neither linear nor predictable. And there are very small cancers with aggressive biology. And no matter when you find them, people generally do not have good outcomes. And there are very large cancers with non-aggressive biology. And almost no matter what you do, those ladies do well, and everyone in between. And so no matter how many mammograms we do every year, the same exact number of women present with aggressive disease. No matter how many mammograms we do every year, the same exact number of women die of breast cancer every year. It's kind of an astounding statistic because no one is talking me about the fact that we are not impacting the bottom line. Not at all.
Well, it's amazing.
Amazing.
I encountered the whole subject of just basic hygiene for breasts, and I encountered the brassiere. And as a male doctor, speaking to women and writing to women about the brassiere, I've always felt severely and appropriately handicapped. But here you are, two of the favorite friends that I have, plus you. Hopefully a new amazing friend, because you're just so amazing to me. Would you tell us more about that subject?
Yeah, it's a touchy subject, right? But the bottom line is that the breast is the canary in the coal mine. And because when you look at the constituents of the breast is made up of glandular tissue. That's the milk producing tissue. That's the tissue that allows us to feed an infant. It's made up of fat. It's very normal to have fat in the breast. It's made up of connective tissue that holds it all together, and that's all encased in a skin envelope. As it turns out, fat is where we store our toxins in our body. And the more toxins you have in the body, the more that is stored in the breast. Now, think about the breast as the glandular tissue sitting next to pockets of fat. Imagine what life is like when you live next door to a hoarder that never gets rid of any of the trash. And eventually, that trash is going to start to spill over onto your lawn and make you toxic. This is what's happening in the breast. Now, the way that we clear out our toxins is by circulation. But there are a number of things that shut down circulation to the breast. First, I'm going to tell you that living in a stressed state is a surefire way of shutting down the circulation to the breast. Because when we are in a stressed state, our body only understands two things. It understands safety and it understands danger. And if you're in danger, it doesn't understand that like your cell phone makes you think that you're in danger. We are very primitive beings. We are modern beings living on a very old gene code. That danger to us is a saber-toothed tiger. So if you have a saber-toothed tiger on your tail and your body is flooded with cortisol, that is saying, I need all the blood to go to the essential organs to run away. The breast is not an essential organ. So if you are in a cortisol dominant state for 25, 35, 45, 50% of your day, you are taking all of that circulation away from the breast. Because your body is saying, I don't need circulation to the breast right now. I don't need to feed an infant right now. Right now, I'm about to get eaten. I don't need to worry about all the rest of this stuff. I'm turning off your immune system. I'm turning off circulation to non-essential areas. And I'm going to increase blood flow to the muscles. Only we're not running away from tigers. We're sitting our ass down in a chair, worried about our deadline or our book. And so that is part of the problem why we're building up these toxins in the breast. And the other part is we're wearing all these tight-fitting clothes. We're wearing bras that shut down the circulation and don't allow for the detoxification. So I'm not telling everyone to burn their bras. I don't know if I'm a feminist or not, quite frankly. But I am saying that if there are times during the day where you don't need it, please don't wear it. Please do not wear overly tight-fitted bras and clothing because they are without question interfering with the circulation, and you need to circulate out those toxins. We talked about all of those xenoestrogens. They are acting directly on your breast tissue, right? That hoarder bitch neighbor of yours is poisoning your breasts. So we have to cut down on our toxins, increase our circulation, increase our detoxification, and that means not wearing such tight-fitting clothing.
And does underwire play a role there?
I think so, because
lymphatics?
I think it only cuts off circulation.
And the thermograms demonstrating, would you speak to that?
Yeah.
How thermograms demonstrate that heat from compression?
I love thermography. I really love thermography. I think thermography got a very bad rap because we touted it as something that it's not. So thermography looks for a heat signal, and where we have inflammation, we have an increased heat signal. So I think thermography is an amazing test for you to look at, scan your whole body, and see, are there areas that need to be addressed? Are there centers of inflammation? And we can use it as opportunity. What it's not is a screening test for breast cancer. And that's where it went wrong for so many people, because there are tons of ladies that had a normal thermogram and then had a breast cancer. There are some breast cancers that are more quickly growing. There are some breast cancers that have an inflammation component into them. There are some that do get that white blood cell infiltration and will have a heat signal, but not all and not most. Most breast cancers are very slow growing. Most breast cancers will not trigger an inflammatory response. And quite frankly, part and parcel to the development of breast cancer for many, many women is the fact that they are chronically immune suppressed because they're in this chronic state of stress, or they have some kind of chronic infection that is kind of robbing Peter to pay Paul. So they either have something in their gut or their mouth or something that is kind of using up their bandwidth. So most women will not have an inflammatory response that can be appreciated on thermography. So I think it's a great test. I just don't think it's a screening tool for breast cancer. So for me, the screening tools for breast cancer are breast self-examination. You can use ultrasound, but it's very low resolution. I do not use MRI. MRI, in order to be a screening tool for breast cancer, requires gadolinium. Gadolinium is a heavy metal. It builds up in your body. Anything that builds up in our body will build up at the expense of something else, something that we need. It is without question associated with chronic disease, neurodegenerative disease, kidney disease. It's probably going to be one of the major causes of osteoporosis. I think that we're going to start to see that data, and it's just not good for you to be exposing yourself to gadolinium every single year, which many of these women who are told that they're high risk for breast cancer have been getting MRIs every year for decades. It's astounding that we are doing this, knowing what we know. And in fact, I was speaking to a colleague of mine who is the head of breast imaging for a very big hospital system in Philadelphia. And she said to me, Jen, I don't know about doing all these MRIs. I mean, these ladies are getting so much gadolinium. And this is from someone who she is running a breast imaging center. Like, this is someone who is very, very, very old school and in there. And even she is saying, I don't know about this. So I don't use MRI and I don't recommend MRI. The other problem with MRI, regardless of the gadolinium, is that the false positive rate is tremendous. And women are getting biopsies for things that they don't need biopsies for. And that's traumatic enough in itself. But people are getting overtreated because they're actually getting upstaged from the MRI findings, saying that tumors are bigger than they are, or saying that there's lymph node involvement, when all that they're really seeing is an inflammatory response or fibrocystic change or some other finding, some other benign finding. And instead of getting lumpectomies, these women are getting mastectomies. Some of them are getting mastectomies and there's no disease at all in the breast. I mean, it's scary, scary stuff. So I do not believe in MRI for screening. What I do believe in, and what I believe will forever change how we screen for breast cancer, is something called QT imaging. So QT uses sound waves. It's transmitted through a water bath, and it creates an actual 3D reconstruction of the breast. Now, when we talk about 3D mammography, like digital breast tomosynthesis, what's happening there is it's very much like a CAT scan. So it's taking slices every 3 millimeters in perpendicular directions. And then what the image that it's creating is an average of all those data points. Same thing that's happening with MRI. It's creating an average of all those data points. QT has 200,000 times more data points than MRI, 200,000 times. And it creates a reproduction of the breast, an actual 3D reconstruction with 40 times the resolution of MRI. So it's not just that the images are better. It's not just that we can see more. It's that it has the ability to count cells. And in doing that, it has functional applications. It is the only imaging that has functional applications. So what that means is that we can see a lesion and we can bring someone back in 60 days. So that is a meaningless amount of time, with the exception of if you have inflammatory breast cancer. And that's a totally different story. That is a clinical diagnosis. That is someone who has a normal breast one day and 1 month later has a breast full with cancer and a big red swollen breast. That's not who I'm talking about. I'm talking about the screening population who goes and has this study, has some kind of asymptomatic finding in their breast. We bring them back in 60 days, redo the scan, count the cells, and measure a doubling time. We know that cancers have a doubling time of less than 100 days. And we know that things that either aren't cancer or aren't meaningful have a greater doubling time. So if your lesion has a doubling time of greater than 100 days, what we tell you is we'll see you in a year. If you have a normal QT scan, if you have no finding on your QT scan, what we tell you is we'll see you in 24 months. Because this is so sensitive, because we know that even if something were to develop in the interval, it's not going to be clinically relevant in that time. At the same time, do I still encourage people to do self-breast examination? Yes, yes. We need to own our own bodies. We need to own our own health. We need to be dialed in. We need to trust our intuition, because no one will ever know us as well as we know ourselves. But I am so grateful that we have this technology now, that women can be safely screened for breast cancer without pain, without compression, and most importantly, without radiation, because we cannot put the normal, healthy population at risk. We can't do it. It's immoral, and it should have stopped long ago. And the only way that it's going to stop is when we demand it, when the women demand it, when they say, no, I'm not doing it anymore.
QT imaging. It's becoming more and more available. Yep. It's available on the West Coast.
It's available on the West Coast. There'll be 3 new centers opening within the next 6 weeks. One on the East Coast, one in the Midwest, and then one in Florida. I hope to have 7 new centers open by the end of the year. And I'm going to put up 50 in the next 5 years. So I'm going to make sure that everyone who wants to safely and painlessly and accurately be screened for breast cancer has the opportunity to do that.
It's one of the most exciting breakthroughs in my quite lengthy career to think.
It really is.
Do you happen to have literature are they studying QT and coming out with the basic science of it? And
so the head-to-head studies with mammogram are done, and they are available on the website at qtimaging.com.
That's great.
I'm going to be doing the head-to-head studies against MR. The problem is that I can't recommend that anyone get an MR. So I'm going to work with the area hospitals in Philadelphia and cooperatively work with them for people who are already getting MR.
Yeah.
Because it's unethical for me to recommend that anyone get one. But if they're already getting one, I'm going to offer to screen them with QT so that we can compare the images, and those images will be done within days of one another so that the findings are virtually the same.
That's terrific.
Yeah.
When you encounter increased breast density, like, for example, in the work that we do, we have women and their initial intake history. We ask them to send to us any recent blood tests that they had, recent or relevant imaging reports. And I can't tell you the number of times we see increased breast density. Anything
Yeah.
specific that you recommend for this?
It's a great scare tactic, isn't it?
Well, please comment, please
Yeah.
elaborate.
So first, let's talk about what that even means, right? So we talked about what the normal components of breast tissue are. So glandular tissue, fat, connective tissue, and the skin envelope. So when we talk about dense breasts, we mean that your ratio of glandular tissue to fat is high. Because when you have a fatty replaced breast, it's very easy to see lesions on a mammogram. But when you have a lot of glandular tissue on a mammogram, glandular tissue and breast cancers look exactly alike on a mammogram. So it makes the mammogram more difficult to read. Now, to have a lot of breast density, I want to be very clear about this. If you are premenopausal, if you are able to get pregnant and feed a child, you are supposed to have breast density. You are supposed to have glandular tissue. This is normal. So if a premenopausal woman has dense breasts, congratulations, you're normal. Right? So we need to stop alarming all of these women who are premenopausal, who are young, who think and are being told that they're at increased risk for breast cancer because they have dense breasts. It's simply not true. That's normal. That's what you're supposed to have. Now, as we stop making estrogen, as our breasts become less stimulated, that breast tissue will start to atrophy. It will start to get replaced with fat. It will start to actually, go away. And as that happens, the breasts become less and less dense on a mammogram. That is also normal. And that is a pattern that we look for to say to someone, you're however many years out from menopause and your breasts are becoming less and less dense. This is normal. What we're looking for, and the only important thing, is when that doesn't happen, or in a postmenopausal woman when her breasts become more dense. Now, the only exception to this is if a woman is on hormone replacement, because we often don't see the same degree of atrophy of the breast tissue in women who are on hormone replacement. It doesn't mean that they're at increased risk of breast cancer. It just means that, they continue to have some hormone stimulation, so they continue to maintain their glandular tissue. The other population that it happens in, and this is the important population, is a woman who has a lot of inflammation is also going to have increased density in her breast tissue and a lack of atrophy of the breast tissue. And that is the woman who needs to have the conversation about you are at increased risk of breast cancer. But it's not for any other reason other than they're chronically inflamed. And we know that chronic inflammation is the recipe for all chronic diseases, including breast cancer. And anyone who shows signs of chronic inflammation, and I don't care what it is, if it's breast density, if it's, you're losing your metabolic health, you have autoimmune disease, like whatever that chronic inflammation is, that puts you at increased risk for breast cancer, puts you at increased risk for heart disease and dementia and osteoporosis and arthritis and all those things. So I think we need to stop vilifying breast density, because in the premenopausal woman, it's absolutely normal, but they're doing a really good job of scaring people and making them think that they're high risk. And one of the surefire ways of a woman getting breast cancer is to convince her that she's going to get breast cancer, right? Don't do that. What happens when you say don't do that? You do it. And we are planting the seed for breast cancer for many, many women. And again, time to stop. I think that whole breast density conversation in the premenopausal population is wholly and all else otherwise inappropriate.
So Boyd classification, BI-RADS, because we see this all the time.
Yeah. So the BI-RADS classification is different, but that A, B, C, D classification of breast density. I think that we're doing women a complete disservice with that. I mean, if you want to start to talk about it after age 55, maybe it's a more appropriate conversation. But in a 40-year-old, to give her a breast density score, I mean, I'm more worried if she doesn't have breast density at 40. Right? That says to me that's someone who also doesn't have their health.
Exactly.
Yeah, and we hear that a lot. I hear that from women all the time who are premenopausal who say, my doctor is telling me I need to have 2 mammograms a year because I have dense breasts. So I'm so glad you tackled that, because that is, it's so common. I think that's what's been, it's certainly circulating around. Yeah.
There's so much fear built into our system. There's so much fear, and it's so unfair. It's really so unfair. And I know that people would make very different decisions if they really were informed, if they really had the opportunity to make informed decisions. And you know, nowhere is that more true than in the hormone population and in the postmenopausal population. I mean, so many women were deprived of hormone replacement for decades because there was so much fear and misinformation circulated around. And there are decades of misinformed physicians who just didn't know any better. And, you know, how many millions of women have suffered as a result and continue to suffer? Right? This problem isn't over. It's not nearly over. And I deal with it all the time when people are horrified that I put my breast cancer population on hormone replacement. They're horrified by it. And, you know, medical oncologists, actually, I had one this week that was like, yeah, I think that she's on to something. I think it's okay. I was like, thank you. Wow. But most medical oncologists, they say to their people, no matter what, you can never be on hormone replacement. And I'm like, can you show me the data on that? Because if it's out there, I'd love to see it. I would love to see it. If I'm doing something wrong, I want to know. I want to know. But as far as I can see, safe, better outcomes, people are healthier, living longer, living happier, that goes a long way. Listen, life is hard when you're miserable. And people who are joyous, people who love their life, they live a lot longer. So, you know.
And there's less risk to women if they're on hormones than if they're not.
That's right.
There's less risk for women who've had breast cancer and had the breast cancer properly treated. They have less risk of recurrence if they're on hormones than
That's exactly right. That's exactly right. And they have better outcomes. And listen, people not on hormones are going to get breast cancer. People on hormones are going to get breast cancer because we have a lot of toxicity in our world and things happen. People who are treated for breast cancer are going to have recurrences, whether or not they're put on hormone replacement afterwards. Right? Because not everyone gets to their root cause. Not everyone changes why they got breast cancer. So all of these things are going to matter.
I love that you're saying that.
Yeah.
I love that perspective is being presented here today. Here's an esoteric subject, or maybe not. There's the whole issue of energy, and the energy we give and the energy we take, the energy we put out, the energy we give out too much of. Is there any relationship to someone like Louise Hay and how she comments about the various illnesses as they're related to body parts? And do you have any experience with that, where women who are more prone to breast cancer might be giving their energy away to the people in their lives, spouses, partners?
Well, I think without question, you know, I don't know if there's data about this, but I can share with you after 25 years of treating women with breast cancer and really, for the most part, being with them from day one of their diagnosis. I can tell you that almost every left-sided breast cancer comes after a broken heart, that there is something in the last 18 to 36 months of their life that just broke their heart. And right-sided breast cancers, I do see in association with difficult relationships with mothers. I mean, this is all biology and it's hard to prove all of this, but I'll tell you that I also can't ignore it. I can't ignore it. And unless you help people to clear this, for lack of a better word, energy, what's to stop the cancer from coming back? Or worse yet, what's to stop the next progression of the disease? Because we have to remember, most women who get breast cancer, they don't die of breast cancer. They die of heart disease. And it is partly because everything that we do in the treatment of breast cancer will damage the heart. I mean, maybe not surgery, but radiation, chemo, all the anti-hormonal treatments, they have a significant negative detrimental effect on heart health. They all accelerate heart disease. Radiation will cause cardiomyopathy. So, there's that. But the other part of it is that unless you figured out why someone got breast cancer in the first place, all of that driver, all of that negative energy, it's still there. It's still there. And it's just going to lead to the next disease state. So I absolutely believe in all of that. Absolutely.
Yeah, it's too bad that I just feel like the current cancer treatments, as you know, it's kill the cancer, burn the cancer, poison the cancer. And it's just like we're leaving out that whole other piece. So it's so refreshing to hear you say what you're saying, because I think a lot of us feel that way. We know that we have to work on the body, but women are often even boxed in and not given a choice. It's like, I mean, I've heard medical oncologists will say, I won't work with you unless you do my regimen, and not really giving women a choice. So it seems there's more and more, we're seeing more of this come out, especially with these integrative oncology physicians or sort of shifting to this integrative approach, just like you talked about at the beginning. But there's, for the number of women who are ultimately diagnosed, we need more providers who are thinking that way, because this is a much bigger picture, as you talked about at the beginning.
It is. And, it is partly because when Nixon declared this war on cancer and we got into this war and warrior mindset, what we need to do is get out of the fight. Like, there's enough fighting. What we need to do is bring peace, is bring joy. And so I don't talk about fighting this. I don't use those words. I don't use those metaphors. I don't talk about winning the war, because we have enough war. We have enough fighting. We have enough anger. We have enough of all of that, all of that imagery. And what we need to do is find peace and establish joy. And when we do that, we shift our chemistry from the chemistry of stress to the chemistry of joy. And we actually create an environment in which someone can heal. But that often requires release of whatever caused that stress chemistry in the first place. And that takes some work. That takes some work.
It's the great work.
Yeah. Dr. Jenn, your book just exudes that piece, though, and it exudes all the pieces that any person can put in place, whether it be releasing the stress or the tension or the toxin, whether it be letting in things that are healing and helpful and hopeful, whether it be establishing a team. You have so many amazing checklists within the book, like what to come to your physician with when you're given that diagnosis. What are some of the questions and terms I need to directly target? I really just challenge any woman, whether they've been diagnosed or not. We're all going to come into contact with either within ourselves or our friend or our sister, or it just affects everyone just because of the predominance that you've already shared. I challenge every woman to just read this book, especially even before you get into the pit or into the weeds of it all, when you can really clearly look at it and all the preventative strategies you have in there. It's just amazing. And it brought me great comfort and peace just to know, oh, there's more I can do. There's more I can do to preventatively care for myself and others.
Thank you so much. My real lifelong dream is to prevent cancer. But unfortunately, thus far, most people don't tap my shoulder until they're in trouble. So, but my lifelong dream is really to prevent cancer. So that's why my next book is The Smart Woman's Guide to Preventing Breast Cancer.
That's fantastic.
So you heard it here first.
Okay.
That's fantastic. Jenn Simmons.
I know.
I grew up in medicine and as a medical student in the presence of giants in medicine, men and women that were physicians that I felt like I was in a temple in my synagogue or my church consistently. And as we meet up with you, I have that exact same feeling.
Oh,
I have that exact same, oh my goodness gracious, here is a real physician.
so sweet. You're making me cry. Thank you. That's so
Yeah.
kind. And coming from you, I am really, I'm flattered to my core.
Thanks for being with us, Jenna. We'll wrap it up here because you've spent so much time, but thank you from all of us. We are so grateful. Thank you for dealing with our technical difficulty. We're here. We're so happy we
It
got to spend this time
happens.
with you.
It
Yeah.
happens.
All right. Thanks, everyone.
Thank you.
Okay.
Thanks for having me.
You bet. Okay. Bye-bye. Take care, everyone.